Health system partnerships are the springboard for growth at Medical Service Company. Our collaborative approach with these partners ensures we understand their current initiatives, challenges, and opportunities so we can achieve progress together. Regular business reviews where we can share data and best practices creates an environment of trust and transparency that all types of partnerships must be built upon. Health systems continue to adjust their care delivery models to reach more patients at home, and many are forging partnerships to help meet increased patient demand for these services. As we consider the entire care continuum, home medical equipment companies play such a vital role in the patient's outcome once they leave the hospital. We are the eyes and ears for the providers in the patient's home, and our team of highly trained professionals are standing by to help. Medical Service Company greatly values our health system partnerships. We take great pride in assisting our partners in preventing avoidable readmissions, decreasing hospital length of stay, and increasing patient satisfaction. If you would like to learn more about how we can work together to achieve these results, please visit medicalserviceco.com to learn more.
We hope you have enjoyed today's educational forum. With that being said, this brings us to our final speaker for this afternoon's respiratory track. I'm pleased to welcome Steve Hartz, who will be speaking on troubleshooting of your home NIV patient. Hartz earned his degree from the Western School of Health and Business and practiced in the field as a sleep technologist for more than 15 years. Also, he is a member of the NBRC. Throughout his almost 30 years of experience, Hartz is focused on spreading awareness and clinically educating audiences in respiratory care and sleep-disordered breathing. With 14 plus years of experience in his position, Steve Hartz is currently the Regional Clinical Specialist for ResMed Corporation. Here, his key responsibilities are to support his sales team. As you listen to this final lecture, you can submit your questions for Steve Hartz under the Engage tab. To receive credit for attending, please complete and submit the evaluation at the conclusion of the session. Enjoy the presentation.
Good afternoon. Steve Hartz here checking in. Thanks for you all joining this afternoon for the 22nd Annual Gene Marx Memorial Education Forum brought to us by Medical Service Company. Steve Hartz is my name. I'm a registered respiratory therapist and a sleep tech. I am a clinical specialist, and a little bit about myself is I'm about 51 years old. I am 51 years old. Great family. My wife, my son, who has 3 children, and then my daughter as well. So just a little introduction to me. My passion of sleep and respiratory came back in 1993, 94. For those who don't know me, I used to tell the whole story. My exit presentation from respiratory and sleep was on sleep, which was amazing. So I'm talking about Colin Sullivan and sleep disordered breathing way back then and the importance. And that kind of transitioned into what I am today. I love my family and I love taking care of patients. So welcome to all of you, those that did know me and don't know me. I told you a little bit more about. But today we're going to be discussing a little bit about troubleshooting your home NIV patients, and synchrony is the key. I also preface the NIV is sometimes talked about life support ventilators and either ST, spontaneous time, their STA alarm devices that you might reference or make reference to as we look through some of the slides here. Let's get started. A disclaimer, I'm currently employed at ResMed Corporation as a regional clinical specialist. I've been around 14 and a half years. I've been especially around the Cleveland area and working with medical service from the beginning. But I spread out from New York, upstate New York, all the way over to a little bit in Indiana and up through Michigan. So big territories that kind of cover 5 states. My passion is respiratory. My biggest competitor has been ignorance to sleep disordered breathing and treating these types of patients. And you guys would realize that have seen me before, the passion I may or may not have, and I haven't lost it yet. So let's get going. Course objectives. One before I even start is here. I always talked about doing something different or changing behaviors. And I'm just going to stick to those couple words. But hopefully by the end of this program, you all will be able to maybe list or explain some of the benefits of remote monitoring systems for the home ventilated patients. List key steps necessary to implement a remote monitoring program for ventilators. review and interpret data offered by current remote monitoring systems, understand the impact of synchrony settings on outcomes, and interpret the impact of the changes on ventilator with some brief introduction to some waveforms. We talk about remote monitoring. It changed sleep when we talked about cloud technology and downloads and cards and things like that. And that's kind of transitioned into what we start recognizing even far back as 2013 with non-invasive ventilation. Patient ventilator mismatching is frequently exhibited in the patients undergoing non-invasive ventilation. Among these abnormalities, patients' ventilator asynchronies are not commonly detected in routine. The detections usually require the presence of a well-trained clinician at the patient's bedside for a reasonable amount of time. I stop there. A respiratory therapist, sleep tech, home, first visit to set someone up. What do you know about these types of patients? And we can understand here that they need us. The patients need us. The physicians might need us to actually tailor these types of patients. And then using remote monitoring to actually make them most comfortable. And I often think about these most comfortable as quality of life, things like that, but also long-term compliance, the key to almost all of this. We spend time at the bedside. The benefits will outweigh the bad. Recognizing this, we see it daily as therapists, as sleep technicians with breathing, if they're on here as well, but daily variations in respiratory rate and percentage of respiratory cycles triggered by the patient might be able to predict the risk for an acute COPD exacerbation. And the use of telemonitoring is feasible to modify therapies in these patients. How about this? Know before you go. Let's stop these patients from readmitting if that is one of your goals in terms of reducing healthcare costs. Be proactive, not reactive when it comes to remote monitoring. And we'll see some of those things in here. And the benefits is you minimize a readmission or eliminate one readmission. You're talking tens of thousands of dollars to the patient and the healthcare system. What's cool is when we talk about NIV, we did it in the hospital. We put them on NIV. We put them on V60s, V30s, VPAP TXs, or excuse me, pardon me, VPAP TXs. But let's think about something they use in the hospital here. It's demonstrated on home initiation of the chronic NIV in the stable hypercapnic COPD patients. With the use of telemedicine, it is non-inferior to in-hospital initiation. It's safe and reduces cost by 50%. Oftentimes, these are started in the hospital. We love that they watch. The therapist can watch. They can make changes. Hopefully, they're looking at waveforms and changes and some of these asynchronies we're talking about. But we also know that it's just as important that if we can't get these on discharge, that we get them at home where the companies can actually set them up. And we have found that it's been super reducing costs and overall safe for these patients. Workflows to improve efficiency. Everybody's looking ways to cut time, drive demand and efficiencies to actually kind of make more money. And when we talk about make more money, it's saving money for the patients, the healthcare system, or the DME world. Old standard workflow that we kind of talk about, and it can be difficult. Every company has a different troubleshooting and a different workflow. Your referrals might demand different things as well. But ultimately, the initial patients and setup, the scheduling of follow-ups, and then interruptive follow-ups, and then ultimately some long-term compliance with these patients goes something like this that we'll see. A busy slide where we're going to kind of drill down into kind of the first ones where we have inadequate therapy. Maybe the settings they got were just some generic settings, a 10/5 with a rate of 12, something without providing blood gases or talking to the patient about their comfort as well. This may lead to your exacerbations of your disease state. The disease states you're often talking about, your heart failure patients, your COPD patients, your neuromuscular patients, your obesity hypoventilation patients. Those patients just keep coming back. We're going to kind of drill down on, we can't stop these irreversible progressive diseases. We're going to kind of try to make the quality of life a little bit better by minimizing these exacerbations of the disease. And ultimately, the goal of every home care is to keep the patient on therapy. It's going to do us no good if they quit therapy, no, for sure. The second pathway we talk about, they're not sure what they're complaining. They're not calling. I can't get a hold of them. But the patient does call in this instance and say, I can't do this. I can't do X. It's too much. It's not enough. I can't sleep, which may lead to some of these unscheduled visits that we might see. All these unscheduled visits, there are costs associated to that. They say $75 to $100 for a therapist to go out, wait for a download, try to look at the problem and look through the download with the patients there, actually change and solve the problem. Do we have to call the physician? Are these changes we can make here or not? And then ultimately answer questions these patients are. What we love to is try to minimize that. What if you could just maybe get a phone call? Hey, but I already know, Miss Jones, that you're short of breath or you're having struggling because I'm kind of looking at you and doing some connectivity monitoring. I'll be able to initially do the set up a monitoring, maybe add some thresholds or management my exception here as I start introducing. Or the patient might calls, I can't do this, family member calls, or you just might see. You go into a remote monitoring system, cloud-based system, and actually you can see before you go a lot of the alarms that have gone off, some data and thresholds that you might have triggered might have gone off that you might see as well. But ultimately, we know connectivity, the impact it's had on sleep, and I'm talking just OSA and non-compliant OSA, and the efficiencies it can provide with these progressive irreversible disease type patients. How many have a program? How many know what your program is? What your duties or responsibilities? When you're talking about establishing a successful program, it is going to take a little bit of time. The time up front outweighs the time that saves in the back. There's definitely some benefits to getting started. You can initiate some of these things on your own. You can look at some data points. You can consult some medical device companies about where to start in terms of monitoring as well, and actually build a schedule. We're talking about often here, I will call them day 1, day 3, day 7. We go out, maybe day 7, 14, 28, and then we do it kind of quarterly. But you have to think about what's beneficial or excessive. Think about the business. Think about the patient. Think about what your referrals expect. That's one thing they'll kind of ask, hey, what's your protocols? What do you do here? If they're not asking, let's start offering some of those protocols and monitoring schedules and see what it might change from patient to patient. It might change from disease to disease. Your scheduling monitoring schedule might be different from a COPD patient or a neuromuscular patient, or you're doing a little ALS type of clinic. You got to create a response protocol. This is often clinicians. This isn't the owners most often, but let's see what makes sense, determine what problems warrants. Why do I got to offer a patient call? What I can change or not change remotely when we talk about respiratory insufficiencies in ST and STA patients, or things you can't change on a ventilator with your chronic respiratory failure patients. Define roles, responsibilities between the DOV and the physician staff. This comes with communication. What do you expect me to do? I bet you the physician office might even say, hey, you have to control leak. Let's get our usage right. You might be able to change some of those unique disease state settings here, but certainly you're going to require a physician staff for a change of a prescription of prescribed settings. Sometimes within these protocols and in those prescriptions, you might see something with some ranges of the roles and responsibilities. You don't have to even call the physician, just make them aware through later on. Also measuring success. Difficult to measure sometimes. This is where you might want to get with the physician, your owner or the company, your salespeople, your clinicians that are case managers that are about, is it reducing readmissions, improving quality of life for your patients, keeping them on therapy for X amount of hours. But how you kind of establish and measure should be reported back. Certainly reported back within the AirView. We can create some very nice reports. But you need to regularly measure some of these accomplishments. I even say share some of these accomplishments and frustrations with the physician, with the referral, so everybody's on board, so they know what we have done and maybe what we're planning on doing and what's the potential outcomes that have been beneficial to the patient. Response protocols. We talk about response protocols should be based on the patient type. When we start looking at downloads and interpreting and disease state management of its irreversible disease, you have to look at the type of patient and severity of the conditions. I always say kind of COPDers, and they can live with like blue lips and low SATs and high CO2s for a long, whereas sometimes maybe an ALS patient might have severity of their conditions, worsen very quickly. So recognizing the type of patients and then the protocols based off the patient. So every protocol might not be one. We don't treat all patients the same as well, but there might be instances where there'll be some uniques where you can clump in a certain type of response protocols and then make it unique to each patient as warranted. I love communication is key. I said about my family, I tell about everybody, I talk about communication is key. Defining communication channel between the DME and the physician staff. Tell them what you're doing, all the work you're doing, the frustrations that you can't, that they might be able to change some of your protocols or suggested protocols that they might have an idea better about the patient as well. But keep those guys pulse, be in there with the good, bad, or the indifferent, and show them all the work that you've done. When you talk about defining roles, this is a great example in here, responsibilities, what parameters should be monitored by the DME staff? That's the discussion that a clinician, I hope there were some clinicians here that are doing sales as well. Maybe they're selling NIV to these physicians as well, but actually saying what you want me to do and what you expect, we expect of maybe the physicians of how do you want to be notified is a great one about some, as an example here, contact the physician if significant changes are seen in the patient's clinical status. A change in respiratory rate and tidal volume, we know there's impending some respiratory failure potentially. Little tidal volumes being increased respiratory rate. If that's sustained, we know they're going to eventually fail. How do you want to be notified? Make them notified either by bringing it in or making some changes, or maybe even having some type of prescription that allows you to have some kind of wiggle room between adjusting some of these parameters as well. Ensure the clinical manuals are available and troubleshooting guides are always available to staff. That's on us. Manufacturers will provide you these clinical manuals. If you don't have one, they could be PDF, they could be saved. You can do hard copies and some sorts of these clinical manuals. But also what I think is super important as we go through the discussion for over here of the hour is troubleshooting guides. I can't remember what he said about doing this and X, and having those available to you is going to provide you some peace of mind, maybe a little less calls to me. And if I don't hear from you, I start freaking out. But, these troubleshooting guides, they say if too much air, you can do this. Just cut me off, you do this. Complain of X, you do this type of thing. So utilize some of these. If you don't have them, reach out to your manufacturer so you can. Contact the physician if the patient fails to remain compliant with therapy or if you suspect change in therapy. Absolutely. Be reactive, not proactive. And we're going to see within cloud-based systems how responsive we can be to change the way we've done any things before. When you're thinking about preparing for home visits, man, might make you a little nervous. You don't know what you're walking into. Maybe you do. But really, when you think about to spend as much time in there or as little time in here, but it's the benefit to patients. So maybe all the time could be reduced when we have cloud-based systems. You should have your prescription ready. It may or may not have ranges on there. You should have a remote therapy report already printed because you go ahead and print that report out even before you go out to the patient's house. You can review some of the parameters, what alarms have gone off, some of the numbers you might see that we'll start looking into. But ultimately, we start looking into, you break it down to really a couple things. Usage. The usage may come from a physician. It might come from just your protocol. It might come from Medicare if they're looking at or a payer that's looking for usage on these types of NIV. That can change. Usages can change. There's little studies out there about the efficacy of, treatment of PAP therapy and reducing some of these overall health cares. So let's look at some of the usage first. but really what affects it is that leak and AHI. Leak screws up everything. I'll say that 9 million times. And I said, how many people leak? And usually everybody screams. Everybody, when we're in the crowd. Looking at AHIs or apnea-hypopnea indexes, you're looking at how well they're being treated. How well they're being treated means if they're still having apnea-hypopnea indexes, they're still waking up to start breathing or start breathing deeper or faster. So let's look at some of that AHI. And then things we want to start introducing here, change in behaviors. We're not only dealing with OSA type patients, we're actually dealing with these comorbid patients. They may be diagnosed or undiagnosed or underlying that we know a lot of our patients have. And we talk specifically mostly to COPD, neuromuscular patients, or some uncontrolled obesity hyperventilation type. Remote monitoring data interpretation. We can now know that with remote monitoring, clinicians can drive, and we say clinicians can drive. You might make up your own protocols. A doctor might say, hey, let your therapist do it. You know the patient, and you see him a little bit more than I do. I just treated him one time. So we're going to be looking for who's not using their therapy. If you don't use it, you're usually coming back in. I share a story of respiratory care back in the day. Pardon me. We had patients come in. They were short of breath. We saved them with our bi-level. We actually kept preventing them from being intubated potentially, or if they were, they went back on their bi-level, but they started feeling a little bit better. And then our little treatment card, we saw refused. They didn't get discharged with any type of NIV. And then actually they're coming back in again. We know we could have helped them a little bit. So using their therapy, not adequately treated. That's in terms of your AHI that we kind of talked about here. When we talk about managed by exception, that's been around a little bit with sleep and groupings and saying, hey, if you break this threshold, what it might be, and we'll talk about some of the thresholds, we're going to get a little click or a tick, into our cloud-based system and saying, hey, they broke a rule set. We need to do something potentially. And that's where we get into what's the roles and responsibilities of who's going to do what. Change settings remotely if you can. If you can't, go out to the house, but also look at and then talk back to the physician about what you're actually doing. Accessing to view ventilator settings and therapy, advance with traveling. That's why I said know before you go, have your vent check all printed out. You can still use your therapy and monitoring and waveforms if you make any changes to find out comfort, because that's the best way that you're going to find out, because you're probably not getting a blood gas, which we know is ultimately the best way. These are the two biggies. We know these AirView and Care Orchestrator can give you so much information. So much information is maybe overwhelming at times, but if you just simplify some of the settings, the thresholds, look at settings, and maybe if you have integrations with AirView or Care Orchestrator in your hospital, if you're coming from that background, you can actually see what's been going on with these patients. Let's look. I've had respiratory therapy departments actually use AirView and these cloud-based systems to even look up some of the settings of when the patients come in, because we never knew what they were on. They don't know what they're on. But this has changed the landscape about how we're going to monitor these patients of respiratory care and underlying diseases going forward. When you talk about how much data you can get, looks super busy, you can simplify it off and say, what's the patient? Are you in the correct patient? Doesn't have it in here, I often say, or we refer to, so we know how to treat patients. That we'll see by the end the difference of treating patients with different settings, how it can affect what's his underlying disease. Why is he on this ventilator at this time? What programs or modes are in here? I see he has 2 programs, and what modes are with those programs. You can drill down into one day or multiple days. You can hover over and actually see some real life data in terms of exact points of data and compare it to night by night. Ones I always look at here that I often see, and I think it's on the next screen too, but is actually someone's tidal volume goes down, the respiratory rate is going to make up. And we often see that in this trending here that we can see. If you want to drill down a little bit more, you can get in some detailed data and look at some things like the respiratory rate as compared to, just for an instance. A lot of data right from these screens. You go ahead and hit print screen. You can take that to the physician. You can take that to, somebody that's going to interpret this, or even some backings on some of your insurances. You have to have some of this for your reporting. This is the second program. This patient was on 2 programs. I know that back up here. We talk about, this is IVAPs at night, and then some mouthpiece with the sys control here. I'm looking at a couple days here. And here's what we're kind of drilling down. You'll always have this bar over here to kind of see if you want to drill down, but guess what's here? And I often talk about it. I'll just keep pointing them out. We'll talk about these things right here. And the question to you is, why are the parameters important? Hopefully you're answering them in your mind. Oh, wait a second or not. When you talk about modes or patients, the first thing you look at interpreting anybody's downloads are kind of the usage, whether it's driven by insurance payers or you want them to use it X amount of hours. Second one down, leak. We can all scream it again. I say, how many people leak? It's everybody. Here it's controlled a little bit with our 95th percentile under 24 liters per minute here, but monitoring that leak a little bit, which ultimately affects algorithms and ultimately reporting. And then your apnea hypopnea indexes. Some devices, life support ventilators, and may offer you AHI that we weren't used to before, but start drilling down on some of these. If you're not sure how to interpret some of these things, that's when you reach out to any manufacturer's clinical specialist to have a discussion. We'll make sure you got the appropriate paperwork, the clinical guides, the troubleshooting, but talk through some of these things if you have to, either with your peers and or some support. This is program 2 of this patient. This is a mouthpiece ventilation. It's on a sys control. There's multiple modes you can put with mouthpiece, including pressure support and PACV as well. But 2 things I think about in this type of thing is it's becoming trendy for mouthpiece ventilation to help with that shortness of breath, maybe give them less squirts, maybe less turn off their oxygen. We certainly know the benefits of hyperventilation with your neuromuscular patients, not having to strap a mask on, a lot more comfortable. And you could be in control with this just by this at any single time. Here it's monitoring tidal volume and respiratory rate. We pointed out here, and I think it's the 18th or something like that. Things I was just looking at, I know this is mouthpiece, but it makes sense. As your respiratory rate goes down, guess what goes up? You go to even that is in with mouthpiece. And that would be the same thing if you're at nighttime. Some of the trends you would see affect other things. And as you look more and more into these downloads in the cloud, you'll see some repetition about treating certain diseases for sure. But respiratory rate manipulation, it says here, when you think about AHI, leak, you're looking at 95th percentiles. A part of interpretation now with respiratory care is actually looking at some median. So if you're looking at some median tidal volume, median respiratory rate, what other things would you kind of look at? And I'll just pause there. Things that impact ventilation. It might be minute ventilation reporting. It might be we're talking about trigger cycle. We might be I ratio, things like that to match a disease of an I ratio of a COPD of 1 to 3, or maybe a 1 to 2 for your obesity hyperventilation, maybe a 1 to 1 for your neuromuscular if you had to. But all the data points you can get there, and the more you drill down, the more you understand some of the changes you can make and drive that comfort. Asynchrony. I always say asynchronies cause a lot by leak. There's a couple different studies that we kind of talk about here and how many are asynchronous with their bi-level or their life support ventilator. This is an oldie but goodie in terms of typical bi-level type of delivery. We're going to kind of drill down on these few points where asynchrony occurs. I often say 5 points. It could be at the trigger or the sensitivity here. It could be with things with the rise time, the peak flow, how fast they're getting the breath. It could be with TI min or minimum time in inspiration. It could be in TI maximum for the maximum time in inspiration. And ultimately cycle sensitivity, which we know is super important in a lot of different diseases. So we're going to kind of drill down on those points, showing some waveforms and talking about the good, the bad, and the ugly. Normal flow looks pretty good. This is from a ventilator here. This is looking at a 15-second screen here, and it'll actually rescale if it needs to. But here you want to look for patient effort, triggered breaths, potentially cycled breaths, tidal volume, respiratory rate. But now we're looking into some waveform, so more natural. We know that most of these are delivered in a square waveform, but you can make and soften some of these with some of the flow measurements or changes we can make here to actually match the disease. How many people breathe the same way every time? None, but that's a pretty decent looking waveform here. We talk about trigger. Defining trigger is transitioning from EPAP to IPAP, or transitioning from exhalation to inspiration. We talk about asynchrony. We talk about the motor or the brain. The why, is it the device or the patient? You can figure out the two when you understand their past medical history or some of these downloads in either waveforms we might be able to see here on this ventilator. What might happen? You might have patients saying missed triggers, or I'm trying to breathe in and it won't let me. Or you can have your auto triggering, which is this thing's too sensitive. I'm not even ready to take a breath in, and what's causing those types of things. The why in some devices. There are devices that have sensitivity settings to trigger. It might be inappropriate for that type of patient. It might be a neuromuscular patient. You might have a malfunctioning sensing mechanism. One that I always say I look for here in the beginning is usage leak, and then system leak is, and ultimately, I don't know if you remember old CPAPs or ventilators back in the day, you had some slop and tubing, and anytime you would almost see those auto-triggered breaths on your waveform on a ventilator, or the patient may be complaining or saying something's going on, but you go in, empty up the water trap, and that flow is now back in. Things that can happen with the patient. We talked about diseases and weakness and muscle weakness, ALS, neuromuscular, end-stage COPD, potentially. How about the decreased neural drive, the miscommunication there? It's not telling me. The dynamic hyperinflation with your COPD is your autopaps or air trappers, however you want to think about it. And then one we often don't think about, we see it in the sleep lab back in the day too. People might even grab their sleep tube and put it on, and you might see some auto trigger and they say it's breathing for you, but it's actually picking up some of that cardiac oscillations and activity from being pounding hearts too. So a couple things to think about in terms of trigger. There's 5 sensitivity triggers in some devices, but make it more sensitive or less sensitive based off some of their complaints or waveforms. We move into adjusting rise time. I kind of equate that to how fast the air's come in or how slow, or the peak flow setting on a ventilator, or, hey, can I hear good air moving in or not? Or the patient saying it's coming in too fast or too slow. And most oftentimes you'll see these patients saying COPD. They require a faster rise time. Think about the way they breathe normally. Short inspirations, quick, decent tidal volumes, but we have to worry about what happens on the back end here. So they might enjoy faster rise times or quicker air. I want more. You might have your other patients that might need softening, slowing down the rise time. Patients who are overwhelmed by too much air or lower slower transition, neuromuscular disease, obesity, hyperventilation. You almost might hear it coming out the mask, potentially. You might see it. The patients are going to complain that it's too fast. You can kind of slow down those rise times or the delivery of peak flow or flows to the top of that inspiration. Those are 2 super common ones that you'll often see, and adjusting those doesn't require a prescription and certainly can be beneficial for either that waveform and or those complaints we might be having, or specific to their diseases. When you look at waveforms here, not the best pictures, and I apologize. When we talk about the top one here, the overpressurization due to fast rise times, Consider slowing the rise time down or increasing the number, so to speak. What you might see is that breath pop off. We looked at that breath where we might say rise time's too fast, where it kind of chaired up and then comes back down again. Not the best picture here, but you can actually help with that by slowing down the rise time a little bit. The bottom picture, the complete opposite. They want more air, they might say. You might see the blip or the hesitation in the waveform down here in the flows or in the pressures. You might see a little bit, but more in the flows here with these patients that, consider moving it to a faster rise time, lowering the number, slowing it down where actually it doesn't bump to go back up. So lowering the number. We talk about inspiratory time. We already discussed trigger, discussed on rise time, slowing down, speeding up, maybe who to consider to do it on. But now when we think about inspiratory time, all that is good, we want to, but maintaining ventilation or tidal volume or minute ventilation has to do with your inspiratory time or the time you spent in inhalation. It could be too long. It could be too short. Start thinking the diseases that it might be too long. COPD, emphysema, cystic fibrosis, chronic bronchitis. Or maybe those that are too short. Obesity, hyperventilation, neuromuscular, restrictive lung disease types of patients. But it is the device or the patient, things you can determine. Looking at your time settings or inappropriate time settings or inspiratory time settings, you can get that data and your cloud-based systems to see what their average inspiratory time might be and set some thresholds amongst that. You can adjust your rise time and cycle sensitivities that can influence your inspiratory time, slowing down that breath or speeding it up for sure. And then you think about patients specifically, their level of spontaneous efforts. What's their disease state? What's their lung compliance and resistance that's causing these too long or too short inspiratory times that might affect their expiratory times and ultimately their comfort and ultimately their blood gases. We see at the bottom again, some trigger sensitivities. We see the variation in the rise time. Now we're talking TI minimum or inspiratory time min setting, and also conversely, a maximum. When would I consider a TI min? I haven't talked about peds here, and I often do. Maybe there is some TI min that we can adjust here for, maybe even your pediatric patients. But for any of those patients that have weak inspiratory effort, we want to make their inspiratory time longer or their inhalation longer, and that will assure adequate ventilation and prevent some premature cycling. So anybody that can't take that big breath in, you might want to consider that changing, adding into a minimum time in inhalation. We talk about the breath and what's under here, a sine wave, it looks like here, but a square waveform kind of under that breath. So if we can make that breath longer in time or the square longer in time, maybe some of these VAPS modes and these pressures don't have to go up as high to achieve the volumes that we have. These are some of the things you're going to change as their respiratory rate changes, their disease state changes, or different disease from COPD to neuromuscular, and when to change these types of things. Now you think about TI maximum or maximum time in inhalation. It limits the inspiratory time. We talk about preventing air trapping and hyperinflation. This is one of the ones that leak can ultimately affect huge. We talk about how many people leak. Everybody, you can time this factor out. Will there be an inhalation at anywhere from 4 seconds down to the minimum, the TI min technically, potentially. But it's based off patient's disease. It's based off patient's respiratory rate. And then ultimately, if you even change it just because we know this guy leaks all the time or this patient leaks, it's going to ultimately help them staying in synchronization and avoiding asynchrony. TI min adjustments. It's a minimal amount of time. We know that. When we look at the first one, that might be setting of 0.1. And I'm not going to guess how much it is, but we can extend that breath out, make that waveform bigger. And anything that's underneath those triangles or those actually is bigger breath. So just by adding a few more points of a second, maybe a 0.3 to a 0.8 or what have you, is going to help ultimately change that patient's ventilation by adding more tidal volume just with time and minimizing the pressures that are needed. Another snapshot from a vent here with inadequate inspiratory time. It's causing inspiration too short. These are the patients, this might be a neuromuscular patient, obesity, hyperventilation, but increasing that alveolar recruitment by keeping them in inspiration a little bit longer, where you can actually see these short little breaths. You're ultimately going to look at tidal volume as well too, and then looking at how long they'll be exhaling here too. We can improve their ventilation without a prescription by increasing your TI minimum time and not even have to call the physician. This is an example to get a better picture. This is from software, Insight software. We can demonstrate what it's doing to the patient if we make changes and then make these changes to see how it affects. We can either do it with a lung, we could do it with you, the clinician, you, the doctor, and actually look at all this waveforms on a breath by breath with a bunch of different devices. Here, it's just saying here, a 0.3 as a default setting here. I'm recognizing what's underneath the square or the breath. I'm also recognizing what it's doing to the patient. We affect how we deliver therapy with rise time and TI min and TI max to affect the patient here as well. So things we often see with the sleep labs, not necessarily at home or with ventilators, but great little Insight software to see all those things that are affecting the patients. Here, we're going to increase it to 0.8, 0.12, 1.5, same pressure potentially. But if we were to be monitoring minute ventilation, I bet you see tidal volumes and minute ventilation go up because now we have a bigger square. If we were using some types of VAPS mode, maybe those pressures would start coming down as our tidal volume breath gets bigger, which is ultimately going to help lower our mean airway pressures. Cycle in the fifth. How many years ago? Some great studies about cycle sensitivity. It's going back 10 years now, 11 years now. Okay, I can see down at the bottom. But the importance of cycle sensitivity and actually transitioning out of inhalation to exhalation or expiration. It could be prematured cycling or delayed cycling. Prematured cycling, you're often thinking about those patients that just can't take that big breath, or the delayed where it's inhalation. These guys saying, I'm trying to exhale and it won't let me. I want to end this breath. Is it the device or is it the patient? We talk about the device. There are cycle settings that you can adjust, sometimes 17, sometimes 5, depending on the device. If you're doing respiratory insufficiency type patients or chronic respiratory failure type patients. Do we have our TI max setting? Because they go hand in hand. Be reminded, TI min and max is a time factor, and either trigger and cycle are flow factors that are affected by the flows and shutting off or transitioning to expiration. Or we know these guys. We got our cycle. We have our COPD. They can inhale good. We talk about they're still in inhalation and they're ready to exhale because they want their I ratios 1:2, 1:3, 1:4 potentially. And what you would see potentially in terms of the prematures, these restrictive lung disease patients, you'd see it blip off way before, after 0.3, but way before your 2 seconds or whatever your percentage of cycle, whatever your percentage of cycle is at medium, high, low, or very low. Tailor those to a disease. You'll see a lot of the repetitive ones here. Restrictive, low cycle. Obstructive pulmonary, higher cycle sensitivities, matching their diseases. You're going to be changing these as these patients' disease change too. And that's what you kind of want. Move through the disease with some of these setting changes. This is a good example of kind of not getting back and air trapping and too much and things I picked up here in the top one was that cycle sensitivity that's popping off on the back end, probably delaying here as well. But You consider decreasing your TI min and or cycle sensitivity, I would add there, to allow alveolar emptying, and then prevent increasing FRC or dead space or air trapping. We want that return to baseline where they can exhale out 3 and 4 seconds potentially, depending on their disease. We know TI maximum will help improve that as well. So cycle is your flow-based, your TI maximum is your time-based. What we look at here is basically on the left-hand side, we're looking at settings with a cycle that's probably medium or so. And then we're talking about looking at here is kind of this exhalation, or what's happening in these exhalation breaths. Here's my COPD here. We want to shorten an inspiratory time. We did by shortening his TI max time. And now we have this amount of I ratio compared to these guys back in the day. In the sleep lab, you might not see it at home unless you're watching them with a pulse oximetry at home, but in the sleep lab, you'll often see just changing your cycle sensitivity or TI max so they can exhale out a half a second longer. You would see some CO2s going down and potentially some O2s rise up by allowing kind of that gas exchange for maybe an air trapper here. A nice piece that we see here from a vent again. I said it was even on those couple slides, back air, inadequate time to exhale, a delay in cycling. They're not returning to baseline. You often see it at the top of their pressure up top here. But things to consider: adjusting your cycle or your TI maximum time, looking at the disease state, looking at the charts provided based off respiratory rate and disease state. Where do I put these settings? Ultimately, consult anybody you need if you don't have that at your hand at the time. We go back 11 years ago, the importance of, and this is what I was talking about 10 or 11 years ago, about the importance of cycle sensitivity and the adjustment of not missing triggers. I've seen this work with kids and COPDers, but it's paramount to match the flow cycles. We know COPDers, as they're diagnosed with pulmonary functions, their flows, their peak flows, are ultimately reduced. But ultimately, we know that their normal exhalation may take 3 and 4 times longer, potentially, to empty out their lungs, where it could be done maybe in normal lungs in 0.4 seconds, where it's all the way out here, past 1 second, 2 seconds, and 3 seconds. We're almost pursed lip breathing and forcefully exhaling. If we can match that cycle sensitivity with the patient not complaining, the waveforms, or some data we're going to see here, ultimately you're going to see the benefits specifically to these air trappers and cycle or TI max settings. In summary, patient's ventilator asynchrony causes serious series of adverse clinical effects and associated with unwanted outcomes such as discomfort, dyspnea, respiratory effort, and decreased quantity and quality of sleep. These patients aren't airway collapsing, they're hypoventilating, causing this sleep disorder breathing, so decreased quantity and quality of sleep. As a manufacturer and a sleep company, is mine get those guys to be quality sleep and quantity sleep, whether they're interrupted by OSA and or hypoventilation syndrome. Instances of asynchrony is greatly underestimated, occurring up to 80%. When we come out, this was 19, I believe. I always reference 40% of our patients were asynchronous 10% of the night. Now here, I obviously greatly underestimated the asynchrony, but if we start looking at some of these data points that we have in these cloud-based systems, we're going to see some of this data and kind of prove how many patients are asynchronous and the benefits of drilling down and changing that so they're not so much. We need strategies to address asynchrony, or a combination of ventilator adjustments and treatment of the underlying disease process. There might be settings you might have specific to a certain disease, COPD versus neuromuscular versus obesity, hyperventilation versus pediatrics. But to be able to tailor and adjust those on a single patient basis is ultimately this is going to be talking about. We need to make adjustments. They might be generic, but also they will be specific as they move through diseases. We know synchrony may not be perfect. Not everyone's perfect. I always say I was in a sleep lab. I always try to make everybody perfect in the sleep lab and every waveform perfect. No two breaths are alike, but provided that the patient is comfortable, the waveforms are looking good or normal or close to normal or matching their disease. And ultimately, to get a blood gas is ultimately the best way to do it. I know it's not happening a lot in the home, but we would know a lot more by getting blood gases. But I hope that you found this benefit, and let me know what kind of questions you have for me.
Thank you, everyone. Hey, Steve, how are you? It's nice to meet you.
Great afternoon. Thanks for having me.
Great. I'm Keith. I'm the regional sales manager with Medical Service Company, and thanks, Steve, for your time and sharing your knowledge and your expertise in NIV. So we appreciate that.
Yep. Keith,
So
just one thing. Special thanks
Yeah.
to Medical Service and ultimately, having a 22nd year of Gene Marx. I've been a part of a bunch of years, virtually now here, which is kind of different, but I'd like just to thank the whole committee and everybody that got this put together. If I can't do it in person, we're doing it here virtually. So thanks again to that team.
Well, we appreciate your time and we appreciate those remarks. So thank you. So let's get to it. We had some questions come in over your presentation, so just wanted to pass them over to you. So first question is, we get a lot of complaints of swallowing air. This is a mixture of COPD and neuro patients. There are times, no matter what we're doing to help, that helps. What would you consider, or what do you recommend?
When you're thinking about sleep hygiene, maybe having them kind of sit up a little bit in terms of positioning to try to minimize that. That's what I'm thinking outside of a device. Certainly looking at any auto feature that's available within a certain mode. So some kind of auto end expiratory pressure that can kind of open that airway at the lowest pressure to try to minimize some of that swallowing for sure. I'm not sure if everybody's going to full face mask, but let's try to, there's that intent with you can just automatically just swallow air just because of the full face mask. Other things that we're talking about that go with the monitoring, the TI controls, the asynchrony would certainly be really adjusting some of that rise time to their comfort as well to try to minimize some of that. And then using some of them ending breath features like TI maximum or cycle sensitivity so it's not as much. But if you are stuck on some type of ST mode and you have to use that, but you can go to some type of VAPS mode where you would get some of those pressures dynamically changing per breath too. That might ultimately help too. So I know there's a whole bunch of different things, but those are just some things I think that you can try without prescriptions and with prescriptions as well too.
Okay, great. Thanks for that insight. All right, next question. In your presentation, you spoke about some of the benefits of mouthpiece ventilation. In your experience, do you find MPV underutilized? And if so, why is that?
Yep. I think historically, the understanding of mouthpiece ventilation has been a lot with our neuromuscular disease patients. And, these physicians out there understand that rescue breath, that chance to give the patient not having to strap a mask on, but actually hyperinflate. I often said it's the old school IPPB with normal saline to try to pop them lungs open and recruit. It minimizes some of that pressures that you might need during the nighttime because you have some of those, things popped up. COPD, it's trendy. It's certainly, we can see where it has its benefits in terms of controlling. I often would say sometimes you say the COPDers or the neuromuscular, if they're on oxygen, they might turn up their O2. You ever heard that when they say, hey, I turned up my O2 because I was a little short of breath? Well, that's not the prescription, sir. We can rescue some of these breaths just with some positive pressure air without having, or minimizing how many of the medicines they're trying to squirt into the back of their throat to have, ease some of that breathing. It's trending for COPD. It's certainly there for ALS, and it depends on where you're at. It's always a great question to ask physicians. What do they believe about that as well? And the benefit of it, that they can have and all those benefits that it might have. So,
Okay, great. Thanks for that. The next question that came over, are ventilator settings affecting synchrony? Are they interchangeable between facility-based and home-based ventilator systems? Or do we need to reevaluate synchrony as we provide different devices in the home?
It seems to me, so it's been a long time since I've been in an ICU with an ICU ventilator, but there's a lot of these settings that the therapists are come accustomed to. Once these home devices come in, it might not be the same name. We might call it a little something different. But a lot of these devices that are coming in from the home, they're hospital and home intended use. So you can manipulate some of that. So some of the pressures might be down, comparatively speaking, from a home device to an ICU device. But ultimately, you can kind of make some kind of transition from ICU vents to a home vent if they have some of that dual limb capabilities or some active circ capabilities. So it certainly can be done. And we tried to make a device that actually could be, hey, it's going to mimic, just like a sleep lab might have what settings they use in a sleep lab, that will equate to a medical services bi-level CPAP ventilator device and have that prescription kind of made right.
Got it. Thank you. All right. And it looks like we have one more question. You talked quite a bit about a leak and its impact on asynchrony issues. When is an acceptable leak for ventilation, or what is an acceptable leak for ventilation? And then also can we still consider anything less than 24 liters per minute acceptable, or should we establish a lower maximum threshold for those patients?
Great question. So they must be dealing with some type of NIV. It's about the circuit configuration and the leak compensation within certain devices. Specific to a ResMed device, we have vSync and vSync Plus, depends on it is. So to simplify it, I always try to think the best leak compensation that we offer from the ventilator is with dual limb technology, and that's up to about 30 liters per minute in excess. The second active and the most is your single limb leak tubing that you hook to a CPAP mask and have vents come out there. That's that 24 liters per minute and under that you want to and everybody knows in AirView and to look under to make sure that that's okay. So dual limb 30, any type of single limb leak, like any CPAP tubing, whether it's on a vent or not, is still your 24 liters per minute. Really good, leak compensation. And then the active circuit that can go to a ventilator with a pressure and a PEEP line, somewhere in between, I believe, 6 to 10 liters per minute of leak. So the worst leak compensation out there. So when you're transitioning maybe from a vent to one of these step down ICUs, look at the circuit configuration and what it can accomplish, because you can only get a certain amount of FiO2 and a certain amount of ventilation and ultimately leak control out of circuit configurations.
Okay, great. Well, that concludes our questions. So I appreciate your response and your feedback on that. Again, appreciate all your time and sharing your knowledge and expertise in NIV. So thank you very much for that. And appreciate the time. So that'll conclude our Q&A session today. And just as a reminder, as we close out our event for the day, we will be uploading the presentations. So feel free and check those out and make sure that you complete your surveys and have those submitted by the end of the day if you haven't done so. So again, thank you very much for everyone joining us today on our 2022 JSM Forum, and we look forward to seeing everyone again next year. Thank you.
It is my honor to wrap up this day dedicated to professional growth and education. Thank you for spending your day with us. Today, we enjoyed the opportunity to learn from the best in the nation in the sleep and respiratory disease management arena. Those of you earning CEUs from today's event, you can retrieve your certificate by clicking on the account link in the left-hand vertical navigation. Scroll to the bottom of the screen until you see attendance certificate and click Request New Certificate. Your certificate will detail all earned CEUs. CEUs were earned through the completion of the evaluations for the lectures you attended today. We want your feedback. Today's event means a lot to us, and we want it to bring as much value as possible to you. Please be on the lookout for our email survey in the next few days. We appreciate you taking the time to complete it so you can help us make this event be the best it can be. In closing, a warm thank you to our speakers, our sponsors, and our fellow DME partners. A special note of appreciation to our MSC team members contributing to this event, especially our planning committee led by Karen Tupas and Julie Banyas. We could not do this without you. Thank you, and see everyone next year.